We can begin.
All right, well, good to see everyone and welcome to the October 27th, 2025 meeting of the ZSFG JCC. And I'm here.
Right. Well, so at this time, this is an information session. It's
Yeah.
not an official meeting yet. But since we have lots of non-action items, we can begin with the regulatory affairs report.
Good afternoon. Emma Moore, Director of Regulatory Affairs. Here to present the October ZSFG Regulatory Affairs Report. So first up, under pending surveys, we still have 4. We did get some somewhat mixed messaging 2 weeks ago now from the Combined California Hospital Association. They had a leadership session with the CDPH, and it sounded like there is somewhat of a pause on federal surveys right now because with the government shutdown. But we did not walk away with a very clear, they will not be doing the 4A survey or the dialysis survey. So it's kind of up in the air, but I think it may, if I was trying to bet money, which I would not do, on which survey happens first, I think it's a little bit more of an even pool at this point, whereas otherwise the 4A recertification survey likely will be the first survey up. In terms of survey activity, you can see there in the month of September, there were two pieces of survey activity. One was a facility reported event. It was a HAPI in the IC efficiencies. The second being that the Behavioral Health Center, specifically the residential care for the elderly, had their annual survey with the Department of Social Services, and they also had no findings associated with that. I will also say, not in the official report, but CDPH is currently on site with one surveyor about 3 self-reported events. So they walked in as I walked out to come down here, but so far that's going well. We had no plans of correction submitted for the time period in question. Moving to our page 2, section 4, our facility reported events. You can see there that our year-to-date total is up to 53, so we have well surpassed 2024, but that is largely in part to the privacy breaches and the sexual assault allegations. And the asterisk I give, it feels like every month, but I feel like it helps, is that the sexual assault allegations, we have come into compliance with the requirement to report all allegations, even if they are immediately unsubstantiated. And with the privacy breaches, one positive thing that I got to see a demonstration of recently is that they have added some software that is able to prevent copying and pasting of PHI into something like ChatGPT or similar services. And so that is genuinely impressive. We've had an uptick in some of those reported privacy breaches, and I'm hopeful that that is going to help us trend in a more neutral pattern.
And if I may quickly jump in, Privacy and Compliance sent an email to me that I forwarded to all of you, the JCC members, around this with a little more detail.
Thank you. So for September, we had 6 reported events. Am I doing that math right? Yes. 1 abuse allegation, 2 hospital-acquired pressure injuries, 1 privacy breach, 1 sexual assault allegation, and then 1 other, which in this instance was the on-campus firearm discharge that had no serious outcomes, which is great. Moving to the next page, page 3, section 5, the plan of correction monitoring data. We still have 2 outstanding items on our report. The detailed information is in the PIPS report, PIPS minutes. But what I will highlight is to say for the second one, the Joint Commission Stroke Survey, we are just waiting for there to be enough 3 months of consecutive data, and they should be good to go. And in terms of that one remaining finding from our Joint Commission hospital survey, it has to do with documentation of patient sniff preference upon discharge. And they, a couple of weeks ago, I think there will probably be more about it, but they went live with a new portion of Epic called CarePort, where they're able to electronically send out referrals. And I've gotten feedback from some of the social workers. It sounds like that's making a significant difference in their actual workflow, which is what matters. But from my selfish standpoint, I'm hopeful that we will finally clear this finding that's been sitting here for 18 months. So finally, there's a significant action that has taken place. Moving to page 4, the complaint data. I did get a question about this, and the reason, knock on wood, that there's no 2025 data is that to date we have not had any complaints in 2025, but we will adjust the graph so that that is clear for the next month. So this is unchanged from the previous month. Moving to section 7, the facility reported incident data. There was a clerical update on page 5, but there hasn't been any significant activity. On page 6, no changes from our prior month of report. And then on page 7, we have some privacy breaches that were updated. So they closed 4 of them where they substantiated them without deficiency, acknowledging that it was a breach, but that they weren't going to give us a plan of correction or a fine. And then 1 was determined to not actually be a violation. So my current, I think, summation of that is that the privacy breaches are managed in Sacramento by the Medical Breach Enforcement Office, and that they are having a more active turnaround of cases, that as we report them, they are proactively investigating them and closing them, whereas from our district office in Brisbane, there is not the same level of activity currently. So we will continue to monitor those. And with that, I will stop for questions.
Oh, thank you. Do we have any public comment today?
We really can't take public comment because, and also there is no public comment, it's just staff. So you can just go ahead and ask.
Yeah,
questions.
are privacy breaches treated identically regardless of the type of institution? In other words, do you feel that other institutions like the not-for-profits at Kaiser are under the same scrutiny and require the same reporting?
From a hospital standpoint, yes, it's technically the same regulation. Any reporting, there is some level of kind of assessment and organizational view. We take a very collectively for all reporting, I think, take a very transparent, collaborative approach with the state. I think that there are other organizations that may not have that same approach, because you actually can look on the CDPH website and look at the facility reported events if you go back several years, and you can see that it widely varies for organizations of similar size. So I think that certainly is a piece. I think it does also go, one of the OCPA's, I think, theories about kind of why we've had an uptick has been the self-reporting aspect of it, that there's been a significant uptick this year. And I think since the SAFE system went live, of people self-reporting that they accidentally disclose something. And so again, I think it really comes back to kind of what is your system of being able to identify events and report them, that I think has the potential to have significant variability.
No, thank you. I had no other questions.
All right, thank you very much. We can move on to the CEO report.
Good afternoon, Commissioner Green, Secretary Morowitz. Very happy to be here to deliver the CEO report. So you're going to be hearing a lot from me this afternoon. I'll try to move through this quickly. I wanted to highlight a couple of items in our in the narrative report. First, we had a really nice visit from District 5 Supervisor Bilal Mahmoud. And this is part of a bigger effort to get all of our supervisors on campus. Many of them are new. And I think now we've had all of the new supervisors on campus. They've all been very appreciative and really astounded by the work we do, which is really nice. We also toured Director Tsai on a tour of our capital projects. We don't spend a lot of time here talking about capital projects, though I know that the commission does get regular updates, but there's a huge amount of work going on campus. And one of the places we went was to see the clinical lab track replacement. And I'll just mention in that context that we had a very successful Beaker go live this weekend. So the lab deserves a lot of credit because they not only went live with Beaker, but they went live with this beautiful new, very state-of-the-art piece of equipment at the same time. So that was lovely to see. We went through psychiatric emergency services, which is still in construction. And we took a look at our 5th floor and 4th floor to see what we have in mind for reconstituting our specialty clinics and our family health center. So that was great. One of the things that I've been hoping to do for many years is to have a place where, hello, Commissioner Guggenheim, to have a place where we can share information and get feedback from all of our staff. And so thanks to our communications team, we've had 2 town halls. Each time we have the town halls, and now they're quarterly, we have one in the middle of the day and we have one at 9 p.m. So we can get staff from across the organization and across shifts. And those have been well attended. We've had really interesting topics that we've talked about, most recently workplace safety, which was fantastic. And then we have lots of new folks. We have a new nurse manager in psychiatry for our BERT team. for KSARC and the Rape Treatment Center. This is Yin Tian. We also have a new leader, nurse manager for 4A skilled nursing, Joyce Loyola. And then we have, not really new, but a newly appointed nurse manager in urgent care, Amy Lee, which is fantastic. So I will stop there with the narratives and see what questions you have before I go on to the data.
Any questions on this part of the director's report or the CEO report?
Yeah,
If you-
just press the red button. Yes.
Hi.
So, welcome to the JCC.
I'm sorry I'm late. That was unavoidable but rude. So as I was reading all your reports, Susan, I was wondering to myself if anything had happened in the last year that, or if things had gone wrong or not right, that if you had something that last year didn't work for you, that next year you're sure is going to work for you.
There's a long list of things that fall into that category. We are very focused on continual improvement. Maybe it would be good when we get into the annual report, we can talk about things that, you know, were new in this year. And I think that would be the best place to start to address that.
Okay,
Great.
great. No other questions on this part of the report. So Mark, should we do the vote part or should we finish the CEO?
Why don't we finish the CEO and then we can go back to the minutes.
Okay.
Also, Commissioner Guggenheim, the data report that I'm going to go through here now gives you a sense of our strategic initiatives and how they've been doing over time. So that also responds to what you're interested in. Okay, so departments driving equity, that has been in the green. There's not much change for that, so I will move on. And I'm going to focus on the ones that I think warrant further comment. And of course, I can take more questions about others. So if you move on to medication for opioid use disorder, this is one of the relatively new things that we've been working on that is very tightly aligned with the DPH strategic initiative around ending behavioral health and homelessness crisis. And even though you're seeing a lot of up and down there, there's a lot of really good work that's going on with this group to increase the number of MOUD starts in the emergency department, in PES, and in the inpatient areas. And keep in mind, in PES, this is a brand new thing, and in the ED, it's relatively new, and we haven't had it be a metric of focus. But you can see our planned countermeasures are expanding PES screening, doing methadone expansion in the emergency department, putting up signage that basically makes these services available or shows that we have them in the ED, and then having ACT consult services available in the ED during business and Sundays. So those are all really important things to increase the starts for these medications. I also want to point out on the next chart, the adult hospitalized inpatient length of stay. Here again, we are still in the red, but it's moving down quite nicely. Our rolling 12-month average is 5.71. Our target is 5, but our baseline from the previous year is 5.8. So you can see we've made quite a bit of progress here, and I won't go through with the countermeasures, but they're listed here on the slide. Our psychiatric metrics are in the green, so I won't pause on them. I do want to pause on the physical assaults with injury. You can see we had a fair spike here in September, and that is very similar to the spike that we had in December of 2024 when we had a single patient that was responsible for many assaults. So, and our teams review these assaults and look to see what was the root cause for the assault and what could be done better. And in this case, there was a specific chair that was identified that could be used that has restraints on it that would have been helpful in this case. So we have a whole initiative around workplace safety, and you know, we look at each of these assaults very carefully. I think that's all on the strategic data. I'll move on to flow data and then I can take questions from there. Percent of time on ED diversion has really come down nicely over time. This is a great example of where we really weren't doing well, where we had an average monthly percent on ED diversion back in January of 2024 of almost 70%. And now we're down, it's 30%. It was 30% in August, as we reported here. It's gone up a little bit. So in October so far, we're at 37%. But what is responsible for this? Staffing. We're very well staffed in the hospital now compared to previous times. We have standard work for going on and off diversion, and we've had also really good improvements in length of stay and boarding in the hospital, which you can see in other metrics. So this is one that we really want to celebrate. I think those are all of the ones I wanted to point out. Well, one more. If you look at the lower level of care, the two bar charts that we have showing lower level of care in psychiatry and in med surg, you can really see nicely how the lower level of care numbers have come down. They still are not at all where we want them to be, but we've definitely made progress in placements out of the hospital. And the CarePort system actually that Emma mentioned is going to be really helpful because it is an automated way for our Department of Care Coordination to refer out to skilled nursing facilities. So I think I'll pause there and see what questions you have on the data.
And we have no public comment, right?
No public comment for any item because there's only staff and no one has gotten permission to provide remote public comment.
Any questions or comments on that part of the report, too? Okay. Yeah, I was just curious, what's going on to follow up on the people that do leave the hospital with the prescriptions? Because I think when Dr. Coffin presented to us, the adherence with, I think it was worse, if I'm remembering right, with buprenorphine than it was with methadone. And so I'm wondering, are there data that you're going to be able to collect to follow the folks that actually leave with the prescriptions?
Yeah, I think I'll defer either to Adrian or Mary to answer that because they're both the executive sponsors on this.
So for a discharge prescription, it's also teamed with a referral for follow-up as well. So those two things together ensure continuation of care. And that's been one of the challenges from the ED, which is why we will be launching a PDSA soon of delivering a long-acting injection in the ED, and we'll deliver that before discharge and then connect them with care. But that gives the patient at discharge coverage, and we can ensure that they've received the medication. But certainly for the inpatient discharges that have that connection with the addiction care team, it is the prescription and then being able to pick the meds up, but it's also the connection to care. And it's those two things together that make the difference. Mary, did you want to add anything else?
Yeah, and I'll just add that in terms of the question around looking at the data, that there are, to your point, Adrian, there are different clinicians. You have to have certain certification to be able to prescribe methadone, whereas buprenorphine, there are less restrictions on clinicians being able to prescribe it. But we are aligning our data with the citywide data so that we can collectively look at outcomes and match patients with the best treatment possible for them.
Are any of the follow-up visits telehealth visits, and would that actually encourage people to engage after leaving the ER or the hospital?
I don't know the answer to that question, but it's certainly something we can follow up when we report on this data next time.
Yes. Thanks.
It'd be interesting to know because you have a great piece, and I think one of these things about the telehealth visits and the number you're doing and the areas in which you're doing them. And it sounds like anything you can do to keep these individuals in the loop would be terrific. So
one of the big assets that we have is our connection with the Bridge Clinic. So we have a Bridge Clinic that's well established at ZSFG, and then next week we're also doing our second site visit to Highland Hospital in Oakland, who also have a Bridge Clinic on site that is very closely connected to their ED. So we're learning from our peers and we're learning from the people around us so that we can make those meaningful connections post-discharge.
And do we know how many of these people also use other substances like meth? Because that's always a huge
The
challenge.
citywide data, the citywide dashboards have that information as part of it, and many patients are polysubstance abusers.
Yeah.
But I don't have the numbers in front of me right
I'd be
now.
curious to know whether those who actually adhere to the program are more likely to be using fewer substances, especially avoiding meth, and whether they show up to visits,
For
you know,
sure.
whether they sleep during the day and use meth at night or whatever, you know, their patterns are. So, well, that's very, thank you. Those are the only
Okay.
questions I had. Is this,
Have we discussed that? A little bit more carefully?
that was, you certainly can ask because it's still part of the CEO report. Go ahead. Yeah.
Sorry, again, that I was late. Can you explain to me how REACH works, how surgical care for unhoused? I'm assuming you're not doing surgery on the street, so there must be.
No.
some-
No, this is a partnership between our Department of Surgery and the WIPIC team. So they basically are able to see patients outside of the hospital and in the same setting that WIPIC does. And I think they actually see them on the street or in the clinic, the MXM clinic that they work out of. But it's essentially making those services more accessible to people who need them. And this is very similar to many of the things, the really creative programs that started the General. It was one of the surgery residents who noticed that people weren't showing up for appointments and they needed a different way to connect with care in order to make sure that they were getting either the surgery they needed or the follow-up they needed from the type of care that they provide.
Very interesting. So it's part of the street team program.
It was a partnership between the two departments.
Yeah.
Good. And the birth, thank you for the birth data, by the way. That's pretty incredible. When I looked at the numbers, the percentages that
Yeah.
don't require any intervention, you see it month to month, and then you see it all is, thank you laying it out there. And it's on this little extra sheet. I asked, you know, the percentage of time that Bert doesn't need to be involved, and it's quite impressive.
Whenever I take people through the emergency department and we talk about the BERT team, the team there will routinely describe the presence of BERT there as transformative, just completely changing the relationship between law enforcement and the clinical teams there, and really doing what they do, which is to de-escalate situations before they even start.
Very, very good.
President, well, the commissioners, I spoke to the folks at Maria X around BERT because I did a tour and I was asking them maybe they could do a training, and they said it's such a different setting that for them the success of BERT would not translate, and they have done trainings, but that they thought that the populations and the situations in which they interact with are so different that BERT does not necessarily sit in the same place. Just as an anecdotal thing, because I was trying to like bridge something in the moment. I don't know if you all have thoughts on that.
Well, so the principle behind BERT is really all about de-escalation, because the truth is for so many years, we relied on the sheriff's department for help with situations that had escalated. And the point at which they typically got involved was when everything is so already escalated that it almost requires them to use force to get the situation under control. And so this is really taking it, you know, all the way back. And it's also true that the sheriff's department is different now than it was years ago. And they also use de-escalation techniques. I mean, I personally observed them doing it on campus recently. And we all have access to the CPI training, which is de-escalation training. In fact, I think we're all required to take it. So it's a different, there's a lot more available in this scheme of de-escalation. Dr. Kanzaria came up because he wanted to say a little more. He should say more about the REACH program because he has more of the details. So please.
I just wanted to add a little bit of additional context. So two of the women who lead the Project REACH, Marissa Bach and Hannah Decker, our surgeons, like Dr. Ehrlich was saying. This is also a really nice collaboration between the foundation, UCSF, DPH, like many of our efforts are. So Dr. Decker has published probably like 10 plus papers on the intersection between surgical care and homelessness, and repeatedly found that unhoused clients have higher rates of unplanned emergent surgeries. So that sort of trick to use data to develop this, assessment of our local population to see where we could do better. They started with a number of PDSAs that were around, can the street-based teams, can the WIPIC teams just have a low barrier to calling surgeons? So they started with just calling Dr. Bach for clinical advice context. And then they've been recently more trialing sort of low barrier drop-in clinic visits. So patients who are well known to WIPIC can show up at any time on Thursday morning, for example, and they'll be seen by a surgeon that's specifically focused on unhoused clients. And then there's deep collaboration between the street-based teams and our general surgery teams, as Dr. Ehrlich was mentioning. So they're working on a number of different efforts in the spirit of continuous improvement, using data to drive their improvement, and then advancing patient outcomes in a really sort of rigorous way that has really been amazing to sort of observe. So I just wanted to add that context.
Thank you. That's great. And also, just to point out that they were the recipient of one of the foundation's Equity and Innovation Grant Awards last year, which is great because there are only a couple that the foundation grants every year now. So this program was exceptional enough to be able to get one of those.
Great. Well, I hope we get a nurse joke every session. It was so cute. Did you see this?
Yeah.
I think, should we make a motion on that? A nurse joke every, we have a quorum.
Yes. Can we step back and I called the meeting to order at 3:18 when Commissioner Guggenheim arrived, but I'm going to take roll. Commissioner Guggenheim
Here,
and President Green.
Present.
And do you mind if we pivot really quickly to the minutes so we can get that over with and then move forward with the annual report? And Dr. Ehrlich, it should be very quick. I'll note that I made a mistake at the bottom and have an extra letter in the word is under Commissioner comments. Other than that, I don't know of any errors. Please let me know if you found anything.
No others. So we'll entertain a motion to approve the minutes.
I so move.
I will second, and all in favor?
Aye.
Great. Thank you so much. Now we can, I believe, go on to the next item, which is the annual report.
I have one other silly thing. In looking at the safety part of here, I was remembering back to 1987, was it, or 89, when the earthquake happened. And it was a kind of terrifying, it was a terrifying time, and people didn't know where to go to feel better. And so they mostly went to the closest firehouse and the closest hospital. And as a result, we then made a map that in 3 different languages that showed where all the firehouses and the hospitals were, and distributed around the city so that people in times of crisis would know where to head. I'm not asking, I can ask the foundation or whatever, but would that make sense again to have that kind of thing that said, this is where you can go when the world is falling down around you?
Yeah, I mean, it sounds like a great idea. I don't know if it already exists. This particular, this drill was focused on drop, cover, hold on. But that's really interesting. I wasn't around, I wasn't at the hospital at that time. But I can check in with our PFER folks to see, how that.
Well, I don't mean
exists.
we have to do it. It just was,
Yeah.
crossed my mind that was pretty much everyone's response in the city to the big earthquake.
And I will actually check with our public health emergency planning folks just to see. I know they have many of these kinds of things, and I'll try to find whatever data that is, and I'll share it with all of you.
Great.
Right.
Right.
Is it okay to move on to the annual report?
Report.
Okay.
Fine with me.
Give me a second to pull it up.
Can I run the slides from here or? do you-
Unfortunately, no.
Okay,
I have to do it from here.
okay. I will direct you then.
Yeah.
What did I do with it?
Well, as Mark is getting that going, I am so thrilled and delighted to be presenting the annual report. I'm going to be going through a PowerPoint that summarizes it, but I know you all have the report with you, and please feel free to ask me any questions about it as I'm going through. I want to give a special shout out to our Chief Communications Officer, Christine Falvey, who worked with a whole lot of people to put this beautiful report together. I think it just gets better every year, and this is just a really beautiful example of everything we've done during the year. Okay, so we start with who we are, and I think you both know this very well. We're part of the San Francisco Health Network of DPH. We're the only trauma center in San Francisco and northern San Mateo County. We're the city's only 24/7 psychiatric service. And one of the many things that makes us special is our partnership with UCSF for the last 152 years. We'll go through the numbers, but we are the city's busiest emergency department with 20% of the ambulance calls, and we serve an incredibly diverse population. Moving on, our mission, values, and vision, these actually haven't changed in the almost decade that I've been at ZSFG. Our mission is to provide quality healthcare service and trauma services with compassion and respect. Our values are joy in our work, compassionate care, and thirst in learning, which is something I have the privilege of seeing every day when I come to work. And then our vision is to be the best hospital by exceeding patient expectations and advancing community wellness in a patient-centered healing environment. This is a lovely word cloud of some of the many numbers that characterize us. Patient served is a little bit higher than it was last year, almost 105,000. You can see we have about 6,000 DPH and UCSF staff on site serving patients. 73,291 medical and psychiatric care emergency visits, 2,200 of those being trauma activations. Urgent care visits, another 51,584. And then outpatient visits is actually the biggest number of things that we do. It's often not talked about, but almost 300,000 outpatient visits on campus. And then babies born is also higher than last year. It's approaching 1,300, which is really nice. Our financials, I won't go through all these numbers, but we're basically we're about a $1.3 billion organization, which is a very significant part of the Department of Public Health overall. And most of that is revenue, is supported by revenue that is not general fund. And about half of our expenditures are salaries and fringe benefits, not including the UCSF staff. Just to say, the reason that salaries and fringe are only half of our total operating expenditures is because the UCSF affiliation agreement captures the UCSF staff in the contract line rather than salaries and benefits. Next slide. Inpatient and outpatient revenues haven't really changed. We are highly dependent on the federal government for our revenues, which you know is kind of perilous at this moment in time. But we're about 2/3 Medi-Cal, 1/3 Medicare. There's a bit of commercial, which comes in through the emergency department because of our trauma service. And that is really what makes up all of our revenue. Next slide. Okay, so here we get into all of the wonderful things that have happened in the past year. And Christine and I tried to pick a few examples. There are many other examples in the report, which I encourage you to go through. But here are 3 of the honors that we received as a DPH and UCSF pair. So our heart failure equity team was exceptionally awarded in this past year, both by the Joint Commission, which received a single national award for their work, as well as the California Association of Public Hospitals. We received a Quality Leader Award from them. Our emergency department, we have a group in the emergency department that has been very devoted over years of getting accreditation to become a geriatric ED. We are now at level 3 accredited, which is the lowest of the 3 levels you can get. But things have really changed in the ED, and it's palpable there when you go down. And then our NICU received statewide recognition from the California Breastfeeding Coalition for excellence in care. Next slide. So these are some other highlights, not awards, but highlights. I really wanted to call out our triage task force in the emergency department. We talk a lot about our ambulance diversion rate, but just equally as stunning is what has happened in the triage area of the ED, which I often hear from our ED colleagues is the largest pod in the ED a lot of times. And basically what they've been working on, which is important in our star rating, is our leave without being seen rates. And they have really put in place lots of systems of care that have been iterated and improved over time that mean that our leave without being seen rate is now around 2%, which is our best practice standard. Last year, we were able to expand perioperative services, adding a 9th room to make sure that we could see patients more timely. This year in the budget, we added a 10th room, which we're very excited about, but we haven't quite started with yet. And then one of our trauma surgeons, Dr. Lucy Kornblith, was honored during Monday Night Football for care we provided to one of the team, which is a really nice recognition. Next slide. None of the work could we do without our staff. And we have been putting effort into promoting staff experience and wellness, both through the quarterly town halls, which I mentioned earlier, and also in our wellness center. We have every month the SPCA comes in with their dogs. That's very popular, as are the chair massages and other things that they do there. Our nursing team is particularly amazing. I know their leader is here, Jillian Otway. And we had an addiction care symposium. This is on the next slide, sorry. And we have a whole other program of educating nurses by the addiction care team to become skilled and certified in providing that care. We had a great partnership with HR this year on hiring. And this Nurses Week research symposium, we had our first ever this year, and it was a tremendous place where nurses could showcase their work. And quality team actually won a big award there for their poster. But it was a really nice way of promoting professionalism among our nursing team. And it was very popular, very well attended. Next slide. Surveys, we have a lot of them. I just highlighted a few of them here. Our Joint Commission biennial recertification for our stroke program, which went very well. Our 4A skilled nursing facility that reopened this year as the Redwoods. You can see the beautiful wrap we have there at the nursing station. And our OTOP team also was successfully relicensed. Okay, moving on to our strategies. I know this triangle looks very familiar to you. We show it to you pretty much every time we're in front of you. But this is a very simple statement of our strategy that starts with patient and community and is underlined by the ZSFG way, our 6 True North goals: equity, safety, quality, care experience, developing our people, and financial stewardship. And on the next slide, I'm not going to go over all these numbers, but this is basically a summary of the work that we did this year. We had 12 metrics, 4 of them ended up in the green. It doesn't mean that a lot of the other ones didn't improve. As you know, we're very aspirational in setting our goals. We have our Hoshin for this coming year scheduled tomorrow. So you'll be seeing some changes in these metrics as we consider the best way to align with our True North goals, to best serve our patients, to best align with the DPH and the San Francisco Health Network strategies. It'll be very similar, but slightly different. Next slide is our capital projects. I mentioned this before, and a couple of things I mentioned: the clinical lab completion, PES, The critical infrastructure upgrades, we've pretty much spent our 2016 bond fund. That was mainly funding the seismic improvements and the IT improvements in the building. Now we had passage of Prop B in November of 2024, which provided funds to do the seismic upgrades in Building 3, which will basically secure our anatomic pathology lab and provide 35,000 square feet of office space that we desperately need. And our dialysis relocation is so exciting. We're moving dialysis out of Building 100, which was built in 1915 and is really substandard, into a brand new location that is pretty much done at this point. And we have another 6 months or so to go with licensing. So it's very exciting. And we have a very active capital and facilities team that is working on scores of projects all across the campus. And I really want to celebrate them because they do a great job. This is a tiny little sampling of the research we have going on at ZSFG. I think people think of UCSF and they think all the research gets done up at Parnassus or Mission Bay, but it's really not true. We have a total amount of research spending of about $230 million on the campus, 1,130 research awards with 376 PIs on campus, and setting incredible standards for care across the campus. And I just put a few examples here in neurology, surgery, and emergency medicine. The foundation, one of our very important partners between UCSF and the foundation. We have our annual celebration in February. It's coming up again soon. And these were the heroes that we were able to celebrate there. This is Mike Texada from the Wraparound Project, Marlene Martin from our addiction care team, and Kelly Margolis from the from the Healthy Steps program. And so it was really exciting to celebrate these. And then we talk also about the equity and innovation grants and our Project Reach that we just discussed a few minutes ago. Okay, community outreach. This is a really essential part of what we do. We celebrated our milk drive. We've actually had 2 of them on campus now. It was really remarkable to learn that we hosted last year the very first milk drive ever in San Francisco and collected more than 3,000 ounces of milk from people who donated it. It was really stunning to see all the people come and donate. And this really helps us start new lives in our NICU. And then that structure behind all those people is a giant blow-up colon. So it was fun to have a whole monument to awareness for colorectal cancer, and we were able to educate people actually right inside that structure. Here, our neurology program had a community health fair in the Western Addition and brought together all kinds of people, including the Wraparound Project and others, to educate about health and hypertension awareness. It was really an amazing gathering. And then we had a lot of activity on International Overdose Awareness Day. We celebrate our staff in a lot of ways. We have our Values in Action Award each month, which is really lovely because it's one of our leaders who passes on the celebration to another leader, and it's just this beautiful virtuous circle every month. So that's our Values in Action. We celebrated Black History Month, and here's just one example of us honoring our ZSFG social workers. And then our patients' voices are very important to us. We have one quote: "The staff was wonderful. Every time I came in, I felt comfortable with the nurses and doctors. We really got on well." And then Pamela Dorsey is a woman who was featured in the San Francisco Chronicle. It was a lovely article about her work with her very large treatment team. And here she's talking about Dr. Jonathan Davis, who saved her life. He really did. Okay, this team, I can't say enough good things about this team. They are Many of them are here in the room. None of this work would be possible without this team. And I feel so proud to support them. I learn from all of them every day. I have fun working with them every day. It's a really exceptional team who are very good at their own areas and good at supporting one another and making sure that overall we achieve our goals for the hospital. It's really an outstanding team. And then here you guys are. We can't do what we do without your support. I am very grateful for your support, for your questions, for just making us better. I really appreciate that. And then in summary, our values: joy in work, compassionate care, thirst in learning. This is what we do every day. And we are grateful, very grateful to the community for support, because we know, just like the way you support us, the way UCSF supports us, the foundation, our whole structure of leadership in the city, we couldn't be as good as we are without that. Happy to answer any questions.
Well, thank you. This is such a stunning report. And as I looked at it, besides the fact that the graphics are remarkable, and I think you're right, that just the way they've done this, it takes real talent. But what's wonderful also is the photos, because they are not posed. This is really the way people look and feel in this environment. And I can't imagine, even if you didn't speak English, you can look at this annual report and know the spirit of the place and the quality of the work that goes on there. And of course, we honor all of you, because I was saying, this is like our happy pill to come here and watch you in action and see this team. And I get a little frustrated at my own place because we haven't quite gotten there, but it's so remarkable to know that it can happen, and that you've been able to pull an amazing group of people together who, as you say, support one another and do such a terrific job. So Judy, any questions on the report or anything?
Yeah, the only thing I wanted to add on to all the people we're grateful for, or to, is we need to remember that we are grateful to all the voters in the city, because there aren't very many cities that have a hospital like this and that fund it, and that the taxpayers want to fund it. And I hear them out there saying, wow, if something really bad happens, I hope I get to the general. And that's a testament to your work, but I think it's also, it's a joint thing. We need always to be saying, and you should be proud of what you're funding, because this is your hospital that you're building.
No, it's absolutely true. It's because we really are dependent on the voters. It's wonderful that we have so much private philanthropy, and we're very grateful to those donors. And we have to get capital bonds approved to help support the infrastructure every couple of years, because 15 buildings and 22 acres, a lot of the buildings started to be built in 1915. It's just a very old, complicated, and in need of help infrastructure.
It's a nice duality. This wonderful hospital and these wonderful people who like the wonderful hospital, or the voters who support it. And that was my thought all the way through this. So
Thank you. Well, you'll both get to hear this all again when I come to the Health Commission to present there.
Yeah, this is wonderful. And the foundation, which you've been a part of, I mean, I think it's also really grown and been quite inclusive, so that more people in San Francisco actually know. You'd hate to have your first encounter with the general be when you end up in the trauma center. And I think a lot of people feel very reassured, in fact, to know that this amazing institution is there and does such terrific
I
work.
know that when people call me because they're someone they know is in the ICU or in the, I always feel really good that I can just say they're in the best place in the world for this. And just one little thing about the hearts, we should also thank Nancy Bechtel and Ellen Newman, who thought up that whole thing.
Mhm.
And it has put us on the map, I think. Certainly put the foundation on the map.
Mhm.
So I guess I wanted to ask my question again, now that we have seen the annual report. Is there anything that you wish, that anything that you saw that you desperately think needs improvement, or more focus from the city, or more focus from the sheriff's department, or more focus from the voters? And is there anything, and if there's not anything like that, have you got something in mind for what you want from everybody for next year?
I would say that the things that we have identified that are most important for us to work on are captured in the strategic initiatives. So if we look at those, I didn't go through all those in detail, but we have flow and access through the hospital. We have quality and safety represented in those metrics there, workplace safety and financial stewardship. And we have initiatives in all of those. And so the things that we need to be the best we can be are the support that allows us to move forward on these things as effectively as possible. And, it's hard in this environment. There's a lot of things that are needed in public health. So I would say those things are the things that, we're really focused on right now. And we work with our partners in the network and in the department to make sure that, we get what we need to be able to do the work.
So is any of the insurance revenue going to change this coming year?
Well, I know that you've heard a lot about HR1 and the impacts that's going to have on the department over time. The effects are really going to start to balloon in 2027. And the estimates are hundreds of millions of dollars for the department. And I think, the city and the department, including the hospital, are going to need to figure out how we deal with that. It's, it's a lot of money. And in the meantime, we're doing everything we can to make sure we're as efficient as possible, that we're bringing in as much revenue as we can, because it's not going to be easy.
Thanks. Right. So I guess we go to the next agenda item.
Yes, and actually, before we do that, would you all mind if I went back and if I read the land acknowledgement, because we skipped that, and that's really
Yes, I
important.
knew we had skipped that.
And I apologize. The meeting was a little bit out of order today. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples. Thank you.
Thank you.
We can move on to item 6, which is the Environment of Care Annual Report.
Good afternoon, commissioners, and thank you for your questions in advance. My name is Chauncey Jackson. I'm the Deputy Chief Operating Officer of the hospital and also the Program Manager of our Environment of Care. It's that time of year again where we get to highlight the tremendous teams and the amazing work that they do, taking care of our environment and making sure the hospital is safe. So as you know, the Joint Commission chapters make up the emergency management team, a small but mighty team, our hazardous and materials waste, which is our safety team, our medical equipment, which is our biomed team, also our security management, and also utilities management, which is led by our facilities department. Next slide. Many leaders, many teams are, behind the scenes making it happen. Like I said, facilities, safety, emergency management, nursing, radiology. There's a lot of leaders and managers that every month, 2 times a month, do rounds of the entire campus to make sure that the facility is safe. And there's a lot of collaboration in person and behind the scenes to make sure that anything that is found, that we make sure is taken care of in a reasonable amount of time. Next slide. We identify risk. We put systems in place to support safe environments. We also assess whether our goals are being met. And like I said before, 2 times a month, a team of 25 to 30 leaders from around the hospital, they meet in that lobby at 10:30 in the morning and they round. They go to nursing units, they go to support staff units, and they really talk to the staff, the visitors, the patients, to make sure that this hospital that we are in and the campus is safe, and also where are vulnerabilities, where are points that we can improve also. And this happens twice a month. And then also at the end of the month, that same team meets to discuss those issues and also identify other risks as well. Next slide. Next slide. Next slide. So first, I'll start with our emergency management. This year, or this past year, it was a collaboration between our hospital and also Pfeffer. We had a leader from Pfeffer that was on site helping our hospital identify risk and vulnerabilities, and at the same time, helping us and leading us through drills. One of the things I wanted to highlight was our Mercy drill, which is our mass casualty incident drill. We partnered with Laguna Honda, other hospitals in San Francisco, and also Pfeffer. Drills like this really get all our leaders in the room, frontline staff in the room, discussing our pain points, discussing what could happen, what could go wrong, what could go right, and really help us moving forward when, unfortunately, real events may occur. And so when those real events occur, these drills put in place will help us with that. One of the goals and opportunities for this year and moving forward is, to your question, Commissioner Green, about our Everbridge system. There was an incident in September where there were some communication gaps that we identified. Since then, our staff has partnered with UCSF to really bridge that communication gap. So if there's an issue on campus, we notify UCSF. We have onboarded them onto our Everbridge system. When they get communicated with, they know that they communicate to the larger UCSF community. That wasn't in place before, but again, sometimes real incidents need to happen for us to know our vulnerabilities. That was one, and we are making sure that that doesn't happen again. Next slide. For our fire life safety management, continuing to manage our false fire alarms. We are having a project in place to replace all sprinkler heads in Building 5. We also just got awarded a new fire alarm maintenance contract for our campus. A lot of this work that I'm going to discuss today, like fire life safety, is behind the scenes. So a lot of this is being led by our facilities director, our fire life safety, and then through rounds throughout the day, these are identified. We are also engaging our staff and our contractors to implement projects that were implemented from the 2016 bond and future bonds for capital projects as well. Next slide. For our environmental health and safety team, they are essential. They work with our facilities and capital. So it's really a large collaboration to look at infection control, to look at noise monitoring during the seismic work, to make sure that any hazards are identified and any risks are identified, and those can be taken care of. Also, the safety team is big in any ergonomic chair fitting. They are also responsible for fit testing. They are also responsible for working with workers comp on how to reduce injury. So a small but mighty team of 3, but these are experts in their field. They also collaborate with Laguna Honda and also central office as well. Next slide. Next slide. So also just goals for the next year is just to continue work with the facility for training and education. Again, because of this work is behind the scenes, it's really important that people know that it exists and that there's a presence and there's also visibility. There's record keeping, a lot of regulatory compliance that team does, responding to issues, whether it's seismic work, whether it is like I said, noise, or whether it is even a slip and fall in the lobby from a visitor. This team is one of the first called to answer those. So our medical equipment management, which is our biomed team, which is our UCSF partners, one thing that they are doing is giving input on selecting a new database for a work order system. This is a work order system that is going to be shared at Laguna Honda Central Office and also ZSFG. So I've been in DPH for 10 years. It's been the same system, and we are getting a new one. And so this is great because it's great for data keeping, efficiency, work orders. There's reports that they're going to be able to give us for us to improve our work. And this is for our facilities teams, all at all campuses, our biomed teams at all campuses, and also our EVS team. So this is a shared database by all these teams, by all these facilities, and we can communicate with each other through this new database. So just really excited about that. The contract was signed and we will be implementing this early next year. Can you go back one slide? One of the things also I wanted to highlight that's just important is that our biomed team is essential in working with the leaders from the hospital, just trying to identify what equipment is also end of life. There's a lot of equipment in our hospital, and many of our leaders in their day-to-day, they rely on biomed to give them that guidance and really show them, hey, you know, this equipment is coming up into life. Here are your options. This is what I suggest you do. And we're really proactive in those discussions so that we are replacing equipment before it goes into life and not doing firefighting or reacting. Next slide. Next slide. So for environmental health and safety, which is also our hazardous materials, same department, just one of the things that we get a lot of requests for that was for a few years was not happening was our ergonomic needs of the hospital. There's many staff who at times may not know who to reach out to for this. This department has really stepped up and provided education and training and chair fittings and provide office hours for those. And that really helps our staff feel safe in their environment and also feel like they're being listened to when they're saying, you know, they're feeling uncomfortable and they're getting assessments done. Our safety team really is there to assist through that whole process, not only in the chair fitting, but also through receiving those from vendors as well and having the vendor come out and fit the employees. Next slide. So this is our work with central office. This is our recordable injuries for the fiscal year. There have been years that it has dipped, like in 2023, but lately there is a trend upward. If you can go to the next slide. This is the same for blood and bodily fluid exposures as well. So with our team who has been put in place for the last 3 years, the more they are visible, the more they are talking to staff know to report these things. And so we have seen an upward tick in the education, the exposures and the reporting, but we want people to report. We want people to report, and then we want to put education in place, not only to decrease that number, but also that people are aware. And sometimes, whether your EVS department or your facilities department, at times, you may, I've been there as a poor exporter myself, I may hurt myself, and then if I don't have that education, I may go about my work. And then years later, it affects me. So one of the things that this safety team does is really letting the team know how to work safe, but also how to report as well. And then also educating the leaders as well. So even though it has dipped, the team is working to have that number trend down, but also have leaders understand how to lift correctly and also how to be safe around sharps. Next slide. So our security management. One of the things that out of many that I want to highlight is, again, this also is behind the scenes work. There's many cameras that sometimes people don't even notice that we add throughout the year. There are screens and cameras that we increase and upgrade throughout the year, software that is upgraded for us to be more safe. And also our Evolve system, Building 5 and 25 at our hospital this past July have a weapons detection at our hospital. This wasn't here years before, and now we are seeing things that, go through the hospital. But that's good because before we didn't catch this. Now we can catch this. We can confiscate it. We can take care of it. And these things are not getting through our hospital like previous years. So these things sometimes are visual that people can see. And then again, there are those cameras or card readers that people do not see that also makes people feel more safe. We just have to get out in front of the people and discuss these things like I'm doing today. Next slide. So some of the performance metrics are our code green response, also our customer satisfaction, and then also I want to highlight our employee security awareness, which is 100%. This security team goes out in the field along with the other leaders of the hospital, and they round and they talk to staff, they talk to visitors, and they talk to staff about, do you feel safe? Do you know what, do you know what we have in place for you? And sometimes the answer is no. But that team is out there discussing with the staff and the visitors, making them aware. And so this is part of our EOC. This is part of the large group that, I'm so proud of, that is doing that work and really seeing the people. Next slide. So here's some data for our group today is threat and workplace violence investigations. One of the things to highlight is that threat management investigations have increased 40% from the previous year. Again, I attribute that to people understanding, having more knowledge, having education, being aware. There is SAFE that is also in place now, and the quality team has done a great job of telling people to please report on SAFE. So as people understand and have more knowledge to report, you're going to see an increase in those investigations. Next slide. And then here are some of the security plans to address some of these threats, whether they're HR, whether they're from the sheriff's office, or behavioral plans. Next slide. Here's some data, crimes against persons and property. Reported crimes against persons and property has decreased 16% from the previous year. Always good when there is a decrease in that. Next slide. So then we have crimes against property. For 24-25, there was one theft in building 25. And then to your right, there were some burglary issues as well, but that number has also decreased from previous years. And then you also can see our use of force by year, which has decreased from 21-22 by 37%. Next slide. So then we can see some of our demographics by high-risk departments, our ED, our PES, also in Building 5, and then also the rest of the hospital. 50% use of force incidents occurred in emergency services, but again, we have a great team there to monitor, and also just, again, it's education. It's just being there in real time and also knowing when and when not to report these things. And I think it was talked about earlier, which I'm gonna get to, our BERT team, which is great in just de-escalating. And that's a great slide that I wanna show you today. Next slide. Next slide. So then countermeasures, BERT, they've done great work. Since this implementation, BERT has performed nearly 21,000 interventions. It is based on a 3-year average. There's an average over almost 4,000 a year from BERT, and I see them myself. They are there, and really since they've been put in place, since I've been at the hospital, they identify with the staff. They are there talking to the staff, and they really are great at de-escalation. And I seen something 2 weeks ago where I was just amazed. It's just by how they're coming in, talking to the visitor, talking to the patient, and they feel seen, the visitor or the patient. And it's great to have that in place at our hospital, and also just understand the importance of having that intervention, and not always having to call the sheriff's office, and BERT being there as that de-escalating team. So really great work by that team. And then for our utility systems, we are supporting security projects. Again, facilities is really big in working with our security team on camera additions, card readers and a lot of software upgrades. Again, this is the behind the scenes work. And then also we are developing a building maintenance plan for assets that have been deferred and long overdue for replacement. So our facilities director and our chief engineers are putting a plan together to address some of those overdue projects as well. And that's all I have. Any questions?
Well, first of all, thank you so much for the report. This work is so extensive and so intricate. And when we look at all the metrics and all the effort that goes into this, it's quite remarkable. Obviously, as you say, it's the background work that keeps the hospital safe and allows the doctors and staff to give good medical care. So we really appreciate your work and your teams. Any questions at all, Commissioner Guggenheim?
No, I just second everything she just said.
Yeah, I asked a few and I appreciate the answers in writing. I did have, are we fully staffed? Is Bert fully staffed now?
I have to defer. Bert, staff, yes, yes.
It is fully staffed now, yeah. Mhm. And then with your emergency management vacancy, I gather you're filling you're filling in that gap. When is that position going to be filled?
So we have a person named Amber Quevlog who's actually on today. She has been amazing. We brought her on in August, and she's an ED nurse. She gets to it right away, and she has created this visibility and this collaboration that at least me personally, and I think others have wanted to see. And she's really hitting the ground running just with her relationships in nursing with not just the nursing team, but physicians, and also bringing that together with the operations team. She's been amazing and just can't say enough good about her.
Oh, thank you. We'll look for, hello, look forward to meeting her. And the other last question I guess I had is, with all of the financial challenges and red tape, I mean, we see it at our place where you think you're going to get a certain instrument and it's not so much end of life on the instruments, but just something that would really make a procedure safer. And, you know, a year goes by and it gets caught in red tape. How is that working for you? Do you try to use the same instrumentation as you see just because you have so many cross-pollinated faculty, or what are the challenges and the issues you think going forward that materials management?
I think in the last year, and shout out to Sabrina, who's behind me there. I really think we have a committee at our hospital that really thinks about proactiveness and talking about equipment, not just equipment for capital that we have to put in for the year, but also what is 3 to 5 years looks like. So we're not having, this conversation in 5 years. And I think we do have challenges, but at the same time, I think in this past year, we have been able to procure equipment because we've thought about it. And as a committee, whether that is from a facility perspective, whether it's our physicians, whether it's our materials management and IT, it is a team similar to EOC that has many members from many different departments talking about equipment, whether that is operational, whether that's for facilities or a kettle in the kitchen or something for the ED as well. So I do think to your question, there are challenges, but I think we've been able to get ahead of some this year with just proactively looking at those areas where the equipment is in need and prioritizing.
Great, thank you. Any other questions or anything? Well, thank you so much for the report. And I guess we go to the next item.
Yes.
Jen?
Well, also I'd like to congratulate you because the manner in which you present is both clear and also concise. You went through a crazy amount of material in a very quick period of time and you did it really well. So thank you.
Thank you, Mark. As always, take care.
Sure. Item 7 is the medical staff report and Dr. Mercer is joining us remotely.
Hello, everyone. Good afternoon. Mary Mercer, Chief of the Medical Staff. I appreciate you accommodating my request to be remote as I'm heading into a clinical shift very shortly. So I'm pleased to present our medical staff report for October of 2025, which will begin with the internal medicine service report, which was quite extensive and really celebrates the incredible diversity and depth and breadth of services of our Department of Medicine, which in the report you'll see that their Department of Medicine at ZSFG, which is led by Chief Dr. Neil Poe, has 13 divisions with 40 clinical service lines, providing both inpatient and outpatient services, as well as it supports 11 ACGME accredited training programs and 2 non-ACGME training programs, and provides a range of services, including both inpatient, outpatient telemedicine, as well as a robust e-consult program, which really helps to address access to care throughout our system for all of our SFHN patients and consortium patients. In the report, it really highlighted a lot of the wonderful work for performance and quality improvement, emphasizing patient safety and continuous improvement that they are continuing to work on in matters of both flow and access to care, trying to reduce inpatient length of stay, to expand services to address the large increase in volume on the clinical service over the last nearly the last decade, as well as programs to improve the quality and delivery of care, as well as equity and access to care. The program also highlighted the very robust research program, which really is driven by addressing, is really a highlight of the UCSF. I believe UCSF overall as a university, I think is the largest funded of NIH resources, and the work that's done at ZSFG through the Department of Medicine is one of the major drivers of that research, really focused on improving equitable, reducing health disparities and improving equitable access to care. And so I think there's a great highlight of the many different research and clinical improvement programs that benefit both our patients and our community locally, as well as society and our global communities. And there are some, I think it highlighted some of the stresses that the program is under right now with the federal administration, specifically targeting a lot of health equity and research, as well as quality improvement initiatives that are focused on reducing health disparities for historically marginalized communities. There is a question in the questions that were sent ahead, just to explain, to provide some more detail on some of the funding that was put in jeopardy, that either has been cut or is in jeopardy for their research program. And I think of the programs that have been completely eliminated, the ones that were associated with USAID, specifically those that were partnered with USAID and working on HIV and malaria, those are the ones that were kind of immediately defunded. Some have had funding that was held, and some of that has returned, but then there are others that are basically still being kind of investigated, and where funding clarification is being pursued. There was some hope that based on some of the most recent disbursements from the federal government, that some of the funding that was paused would be was actually instead continued. And so we have the UCSF departments have come back and have received some of that funding, but I think it remains to be seen what will be funded in terms of priorities going forward for the next year's budget and for new grants. So it's still an evolving landscape, and I'm happy to take any questions about that or about any other aspect of the Department of Medicine report, and we can certainly bring back more detail based on what your questions are for that report. I will also just clarify there's, I guess it's close, I'll stop with the report and then we can go into the clinical service report and the rules and regulations update.
So any questions on the internal medicine? It's a remarkable department. It was such a pleasure to go through the slides and see all of these amazing people, and the way it's just such a large department. It's so well organized. And when you think about all of the divisions and how they work together and the leadership, it's really kudos to everyone in that department. It's just amazing. So I guess that we'll go on to now the
Sure. So within the clinical service report there are just some minimal changes, administrative changes and some new positions that were added to the medicine service report. And in the rules and regulation, again, some administrative changes that were noted there. And I'm happy to take any questions for that item.
Yeah,
And then if not, I can go on to the credentials, not the credentials report, but the other standardized procedures. There was the standardized procedures for nursing that was put forward for hypertension. I think there was a question there about why this particular standardized procedures was put forward. And this one aligns with other standardized procedures and protocols that are followed by our affiliated professionals and were updated to reflect the CDC guidelines, but these were specifically the nursing standardized procedures. And then the other privileges and standardized procedures that were submitted as updates were administrative changes and updates for both hospital medicine report.
Great, thank you. Any questions? Sure.
How many staff are we talking about? How many people do you have underneath you who are doing medicine, surgery, all of the?
Oh, sure. For all of the medical staff?
Mm-hmm.
So for all of the medical staff, I believe that it's about 1,500 clinicians. I'll give you the exact number for those that are active as of right now. It's in the credentialing report. 1,550 total members and affiliated professionals. Between active staff, courtesy staff, so those are the volunteer, or not volunteer, but some are volunteer faculty, and then some are faculty or clinicians that work less than half time at ZSFG, but might be providing specialty care services within ZSFG, and then affiliated professionals. So those are non-physician or dentist professionals, so nurse practitioners, physician assistants, pharmacists, etc. Within the Department of Medicine, they have about, I believe it's 800 faculty and staff across all of the divisions of internal medicine. So it's essentially half of our medical staff or affiliated professionals at ZSFG are within the Department of Medicine.
That's a force.
Yeah, the scope is incredible. So we have to entertain a motion to approve, to recommend to the whole commission the rules and regulations and the standardized procedures, right, Mark?
Yes, and Commissioner Guggenheim, this is the procedure by which things get put on the consent calendar where you approve them at the full commission. The committee reviews them here and recommends, so that you're now on the committee today for that purpose.
Okay.
So we need a first and second for that.
I will recommend that we recommend these to the whole commission.
I'll second that recommendation.
And
All those in favor?
aye.
Aye.
Fantastic. Thank you, Dr. Mercer, for appearing
You
in
have a
between
deep-
your.
Hope you have a decent shift.
Thank you. It'll be very busy.
Okey doke, we can move on to item 8, other business. Hearing and seeing none, we can move on to public comment. I see no public in the room, so we can go to a consideration for a closed session.
So we'll entertain a motion to go into closed session.
I so move.
I will second. All in favor?
Aye.
All right. If someone could close the door, please, in the back. You don't have to close it hard, but just so that's not open to the public. And also, not everyone in the room here, I think, needs to be, yeah, I was going to say needs to be in the closed session. That's great. And give me a minute to take us over to the closed session. Back in open session. In closed session, you all approved the credentials report and the PIPS minutes report. Please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second.
All those in favor?
Aye.
Aye.
All right. And please consider a motion for adjournment.
Move to adjourn.
Second.
And before you vote, thank you for joining us, Commissioner Guggenheim, to allowing us to have quorum today. All those in favor?
Aye.
Aye.
Okie doke. Thank you, everybody.
It's my honor.
Always.